know about your family's medical history? How about those genetic conditions that could affect all of you?
There's an old Chinese proverb about doctors. An average doctor treats the full-blown disease. A really good doctor catches it early, and an excellent doctor prevents the disease from ever happening. And that's where we're heading. And that's where we're really going to have a huge impact on a lot of people's lives.
That's Dr. Darrel Gumm, Vice President of the OSF Cardiovascular Institute, and I'm Shelli Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. Personalized medicine. Think about it. If you can get health care specifically tailored to you, your family, especially if it can make a positive impact on your life, most of us would do that, right? Through OSF Innovation, we are working every day toward that level of care, leveraging big data to tailor unique care to individuals. One of those areas has to do with your heart. It's called familial hypercholesterolemia, or FH, as I will refer to it throughout the rest of this show, which is a genetic predisposition to high LDL, what's known as the bad cholesterol, and can cause heart attacks in younger people. And when I say younger people, we're talking 20s and 30s. It's that young. Joining us for this conversation are Dr. Darrel Gumm, a cardiologist and the Vice President of the OSF HealthCare Cardiovascular Institute, and Ryan Loudermilk, Strategic Program Manager in our Ministry Performance Improvement Division. Before we take a deeper dive, welcome to both of you. And Dr. Gumm, I want to start with the health perspectives of it. As a cardiologist, tell me about FH and why how it works and how it affects someone.
Yeah. Thanks so much, Shelli. FH is, first of all, way more common than we thought. About 1 in 200 people have it. And that means it affects about 1.3 million Americans. We estimate that about 10% are aware that they have it. So a huge gap in knowledge. And to know it, it's very treatable, but if you don't know, you don't get it treated. So, and of course, the consequence of untreated high LDL, we know that LDL is the particle that gets in the vessel wall and creates plaque. So untreated LDL that's running very, very high is rapidly building up plaque in people's arteries. Of course, the most fatal would be the heart, but carotid arteries and elsewhere, the legs, etc.
So what are some of those symptoms? If I'm going along, and how am I going to be affected? How will I notice high cholesterol is affecting me? Perhaps if I'm not going and getting tested. Let's be honest, 20 and 30-somethings aren't doing that.
That is exactly right. Now, there are people where the LDL, so we consider an LDL cholesterol of 190 to be alarming. But there are people where it's 400.
Oh, my.
Now, so you don't feel your cholesterol, obviously. You can't tell that. But when people are in that extremely high range, they can get physical characteristics where areas around the eye, the tendons and the Achilles tendon will thicken up because of that high cholesterol. So there can be physical signs in the extremely, extremely, extremely high. If someone's hearing this and they're saying, I think I remember mom used to have that, well, that you should go get checked, because if she had those physical or he had those physical manifestations, then there's likely that person did have very high LDL and was probably an FH patient.
Yeah. So, this just all sounds scary. The lack of knowing that you have this. And that's one of the biggest challenges, isn't it, Ryan, that people just don't know what they don't know, right? Because I think there was a certain generation, you didn't ask those questions. Oh, we do. Grandma and grandpa dealt with that. And you'd hear stories, you'd hear tales, but nobody talked about that. Is some of that what we're also trying to break those walls down to?
Sure. I mean, you could be walking around healthy and have no idea that this is going on in your body, especially when you're younger, and you could be an athlete and have no idea. You basically have this ticking time bomb really going on in your body. So that's what makes it so challenging for us to identify.
And you're right. We have these patients. We have people who say, I don't want to get my blood tested. I don't want to know that. I equate that to saying, I'm going to put a blindfold on and walk across the street because there might be a bus coming, and I don't want to see that coming. Okay.
Yeah.
If you've got high LDL, there's a bus coming. You're walking across the street blindly. You should know it, and then you can take the proper steps to prevent a disaster.
And that it's as simple as a blood test, right? This is not some other invasive thing. It is a boom, draw when you're getting the full range of blood done.
It's a fasting blood sample that will tell us a person's baseline cholesterol, which will include, that panel will include their LDL.
Yeah, and we don't mean to scare people, but when you just said those numbers, the proportion of people who might have this, that's alarming. And some of the work that you do, Ryan, through performance improvement and identifying some of these things, let's first of all talk specifically about FH. This is an AI-driven, you go through and how does that work? It's picking out pieces and parts that identify, this person we may need to follow up on.
Well, what we're doing is Dr. Gumm and the clinicians that we've been working with is kind of identifying an algorithm for identifying patients that are going to be high risk. So we've been able to use AI and some other analytical tools to look at current patients that have been getting their LDLs checked to see if they are potentially high risk. And that's really what we're trying to do, is bring those patients in, see if they have FH. And really the big bang for this is those people that have not been getting their cholesterol checked. So say your dad goes in and he gets checked and finds out he has FH. Well, now we want to do this cascade screening to check for direct relatives that may not have even been having their cholesterol checked and find out if they have it and actually start checking. So that's what's exciting.
Do some people think, I'm guessing there are people think, well, as I've gotten older and life happens, and okay, I might have eaten a few many times at the fast food restaurant, and that's what's contributing to this. Is FH driven by that type of stuff, or is it genetic and I'm going to get it one way or another?
It is genetic, and it is not modified by lifestyle changes.
Interesting.
You must be treated if you have FH. You will have, everybody should be eating heart healthy and living a healthy heart healthy lifestyle, but it will not change the outcome for FH. These people are going to make way too much LDL, and they will get in trouble as a result of that.
And how is it treated?
It's treated with statins typically, but statins and a variety of other medications that we have, particularly the PCSK9 inhibitors, a new injectable form of treatment that's available as well, that dramatically affect the LDL. We lower a person's risk, just with statins alone, we can lower the risk of a cardiac event or stroke by up to 80%. It's tremendous.
Wow, that's a significant number to throw out.
And just stopping your McDonald's visit isn't going to be enough to make that difference.
Well, yeah, and again, I'm sure some people are going along and then are probably surprised, because you do hear these stories of 20 and 30-somethings, or they had and you see the obituaries, unfortunately, and sudden cardiac event in their 40s and 50s, and you just wonder. I'm sure your head goes to lots of questions that are probably not addressed.
Well, yeah. So you always worry about, was this just a guy who was smoking 5 packs a day, and was it all a lifestyle, or is it, really at a younger age, we do consider lifestyle for the general population to be about a 75% impact on longevity, with genetics, playing a lower incidence in the general population. As you get older, it's interesting, as we get older, because, you've all heard about the 100-year-old or 99-year-old that says, where's my cigar, my daily cigar? I need my little shot of whiskey before I go to bed. So lifestyle becomes less important as we get really old, but very, very important when we're younger. And so lifestyle is important. Again, for the FH population, this is a genetic defect affecting 3 different parts any of these could be thrown off, and they are going to produce very high levels of blood levels of LDL.
Let's talk a little bit about some of the AI stuff. You throw around the terms artificial intelligence, and people sometimes get a little freaked out about it. They're going, oh no, I don't want you in my business. I don't want you looking at things. From your perspective, AI is a good tool, isn't it?
It's definitely a good tool. It makes us more efficient. It can make us more accurate, by searching for things that would normally take a regular person to sift through data, hours and hours and hours. AI can help us and do it like that. So it definitely changes the game and elevates our level of science and our level of experience, all of it.
And it's looking for things that are entered into public records or medical records from a person. Does it concern you, again, as we get the word out more about some of this work, younger people don't have a tendency to go to find a PCP. They'll go to an urgent care when there's something going on, and I need this taken care of now. they, over the years here, they have not developed that long-term relationship with a family physician that might spot some of this or ask those questions. Is that why some of this work is also very important?
Well, absolutely. So a whole bunch of things that could be picked up early are very important. But if we can identify an index case, so we find one family member who's got these extremely high LDLs, screen, discover where is the genetic defect. Now it's an easy thing to go look for in all of their first-degree relatives, older and younger. And really in families that have a high risk, we would recommend that as young as 2 years old should be screened. Because the sooner you pick this up and begin the treatment, the sooner you prevent the laying down of plaque in all these critical arteries that are carrying blood to vital organs.
Okay, that number is startling, a 2-year-old to get it checked.
In a high-risk family.
Yeah.
So we find a 35-year-old comes in with a massive myocardial infarction. We discover his LDL's 250, let's just say, for instance. We'll say, tell me more about your family history. Oh, yeah, Dad died early. My brother had okay, let's keep going. I have a 2-year-old at home. Okay, we need to get some blood work done.
Yeah, knowledge is power in this case.
And really, the interesting part is the test itself for getting your genetic testing is very simple. And for this one, it doesn't even need to have blood drawn. It's just a simple swab inside your cheek to check this.
Really?
So very easy.
Oh, yeah, that's simple. Well, let's go a little further into that genomic research. I know you two get very excited about the Human Genome Project. Let's talk a little bit about that and the exciting things that lie ahead, because in a way, it ties in to this FH conversation and how this will become even bigger and broader.
Yeah.
Tell me about it.
Yeah, I think that generally the Human Genome Project, I think, is considered probably the greatest scientific achievement of all time. This goes back to the concept. It was 1988. In 1990, they started this project with a lot of resistance from scientists saying, look, we're going to be spending hours a week, getting every single base pair in the entire human DNA, 3 billion base pairs in the human DNA. But as it went on, technology developed, it got better and better, got faster and faster. And over a 13-year period, they were able to map the human genome to about 92%. So just about 400 gaps in the genome at a cost of $3 billion. Now, to give you some idea of what's happened with, really we call it AI, it's computing power and computing memory. Now today, a human genome can be done for about $600, and the turnaround time is around 2 or 3 weeks. We anticipate later this year that price should drop to about $200, and there's technology coming out later this year that's anticipated to drop that price to $100 for the entire human genome at twice the speed that was being done before. Absolutely amazing. And this brings us back to FH and personalized medicine on a whole bunch of scales as we identify certain things and you know where to go to look in the genome to discover, do you have that mutation or do you not?
And is that going to be done by a swab?
And that's going to be done by a swab, a little scrape in the mouth. Isn't it just incredible?
I can just see Ryan sitting here going, you're like almost drooling over the thought about this.
Oh, yeah. I mean, the opportunities are endless. We have lots of things that we have to work through to be able to do all of this, but the opportunities are really exciting.
Yeah, the ability to detect DNA. And, I'm in medicine. 2 years ago, my daughter-in-law announced that she was pregnant, only about, I think, 8 or 10 weeks pregnant. She said, by the way, we know it's a boy. And, because I was not in OB, I didn't realize, because I thought, well, you had to wait till you're at least 16 weeks to get an ultrasound, or they would do an amniocentesis and actually check the genes. But even back then, the technology was very well spread around that they get cell-free DNA in the mom's blood. So you're 8 or 10 weeks pregnant. They draw the mom's blood. They find cell-free DNA. That's the baby's DNA floating around in her blood. They analyze it. They can tell gender and screen for a bunch of genetic defects. Unbelievable. How they do it, I have no idea. Just incredible.
Well, and the exciting part is like when you say get the whole genome tested, now, because the science is still going, he talks about all the work that the Genome Project's done, but they're still identifying other mutations, things like that. You still only have to do it once. There's a lot of companies that are working on, they store that data, and as new science comes forward, they can actually go recheck and be like, oh, you actually have this now that we just discovered. So it's not like you have to keep doing it over and over and over again.
Yeah, that's even more exciting to think because you are born with one set of genetic makeup. It's here. It exists. Now we need to see what it is. OSF Healthcare being a part of this. How exciting is that to work for a healthcare system and through OSF Innovation? We work all the time on those type of things, but on a daily basis, you're doing that work, and that has to be very exciting.
It is very exciting, and I tell my program team that I have for personalized medicine, I'll give a shout out to Kyle Rice and Marilyn Colgan. They're working on the FH and working on Cancer IQ. I tell them all the time, I'm like, this is the cool stuff that we get to work on, not some of the kind of minutia, mundane things that we sometimes work on. This is exciting.
Yeah, because you can see it long range and where it goes. So what other things are maybe sitting out there bubbling on the surface that maybe it's on a wish list of things that we want to do, but this will open the door to that?
Sure. This is one of the big ones. And we started with Cancer IQ, which was, doing a risk screening survey to identify your high risk or not and get you in to do some testing, talk to a genetics APP or a genetics counselor to see if you're high risk or have a gene variant to make you high risk for certain cancers, to change your screening, changing how you're preventing these things, identifying cancer earlier. We're just now really starting to work in pharmacogenomics, which is the genetic testing to look at how you actually react potentially to drugs or ones that you don't, which is really exciting because we're prescribing medicine all the time, and there's areas in Dr. Gumm's area with statins that we want to get to. There's lots of opportunities in oncology with chemotherapy drugs that we can be doing testing that can actually tell you before you get it prescribed what dosage, should you be on a different medication or not. It's just exciting the things that we can be able to do.
A great example of that is you mentioned in cardiology, a drug we use commonly is Plavix, and Plavix is a prodrug. And it must be broken down to be activated. So you take it, and then it's broken down, and now it becomes activated and has the active compound. Well, we can screen people and discover, oh, you're not going to break this drug down, or you're going to break it down so actively, you're more likely to bleed. You're more likely to not have any effect. And the same system that does that also affects certain antidepressants. So you can imagine, and I think, the future is there will be a spot in Epic that holds your DNA. And when I go to order this antidepressant or I go to order Plavix or whatever, it's going to say, it won't work. This patient will not metabolize that drug. It will not turn into the active compound, and they will get no effect.
And Epic is actually already working on this, and we're in the process of trying to integrate that and build it for use cases already.
Really exciting stuff. And, again, this is one of the great things about being a physician with OSF Healthcare, a very proactive, cutting-edge system that allows us to participate in these kinds of things and really deliver, ultimately, patients win.
You've been practicing medicine for more than a few years. I've known you a number of them. Did you ever think you would get to this day when you started your career? In cardiology already, you have a very specialized what you're looking for. Did you ever in your wildest dreams imagine you would be working like this?
Yeah, it is. Yeah, it really is beyond the imagination. And, you see it at multiple levels of how medicine has progressed, but particularly in cardiology. We go back to 1977. This radiologist by the name of Andreas Grünzig in Switzerland decides to put a balloon inside a guy's coronary artery. Everybody thought, this is crazy. You can't put a balloon in there. It's going to be a disaster. And he did his first 5, and they all did great. And today, we're putting in stents. We're not stents. We're putting in valves in people and modifying valves, all being done percutaneously. So you start with something that's minimally invasive. You show it can be done, and then it goes on and on and on. And now, very analogous to that is what's happening here. Things that could you imagine? It's always been trial and error. Medicine's always been trial and error. Okay, I think you've got this. I'm going to give you this drug, and let's see if you get better. Well, I didn't get better. Oh, okay. Well, then let's add this one to it, or double the dose. Maybe that'll do it. So we've always had that. Can you imagine we get away from that to greater precision? We go more quickly to the right diagnosis. So that's great. So the person gets treated more effectively, more quickly. But how about to be able to prevent? For years I've been telling my patients, trying to encourage them just to adopt a heart-healthy lifestyle. The best way to take care of a heart attack is to not have one. Okay. The best way to take care of a stroke is don't have one. So if we can pick up teenagers or people in their 20s who are on that path, I mean, you think about that. 1 in 200 population, 1.3 million people affected by FH, and only 10% know it. 90% don't even know they have it. The potential here is huge to get to those patients and really impact them. And again, way better than treating the heart attack is to never have that heart attack in the first place.
Well, like you said, it's 1 in 200, and you're actually 20 times more likely to have heart disease if you have this, which is a huge number.
Yeah. Okay, we could probably sit here all day and talk about this, but we're going to wrap it up. I'm going to ask both of you, what excites you the most about this work or the work as you're looking into that crystal ball down the road that lies ahead in the not too distant future? Ryan, I'll start with you.
For FH specifically, what's exciting to me is someone that's, been an athlete most of my life, and, you could be having a 25-year-old marathon runner who has no idea that he has this and thinks he's healthy and doing all the right things, and this genetic issue could cause him to have a heart attack really young. So it's really exciting that we can identify this earlier and, head this off, and, maybe we'll make him less busy by getting these patients checked. And the sky's the limit. I mean, really, pharmacogenomics is really exciting. If we can be doing whole panels of testing and being able to, like he said, I get this alert that says, wait, you shouldn't prescribe this medicine. They would actually do better with this one because of their genetic, predisposition to certain things. It's exciting.
Yeah, really along those same lines. And I'm trying to remember there's an old Chinese proverb about doctors. An average doctor treats the full-blown disease. A really good doctor catches it early, and an excellent doctor prevents the disease from ever happening. And that's where we're heading. And that's where we're really going to have a huge impact on a lot of people's lives. Well,
Dr. Darrel Gumm, Ryan Loudermilk, thank you for this conversation. I'll look forward to revisiting down the road, especially when we get into some of the more of the pharmacological uses of this and see where we go from here, because it's very innovative and very exciting.
The other thing I've been telling people for years, where I would find a family I said, listen, you need to understand we've got to treat you, because although you can change your Levi's, you can't change your jeans. So, it's my dad joke.
It is your dad joke. And so, again, as they jokingly call themselves the best mustache and the best beard at OSF HealthCare, thank you for a great conversation, and thank you for joining us as well. And a reminder, you can find all of your OSF Healthcare Accelerated podcasts at osfhealthcare.org/accelerated.